Hello, I'm Dr. David Rubin. I'm a professor of medicine and chief of the section of gastroenterology, hepatology, and nutrition, and I'm also the director of the Inflammatory Bowel Disease Center at the University of Chicago. Welcome to this Medscape podcast titled Inflammatory Bowel Disease: Why Mental Health and Wellness Matter. I'm really pleased today to be joined by Dr. Elise Bedell, who is an assistant professor of adult psychiatry and medicine and the director of the psychogastroenterology program at the University of Chicago. Welcome, Elise.
Thank you so much for having me.
I think you would probably agree with me, and of course, we work together, so I know what you're going to say, but that mental health is an underappreciated aspect of living with inflammatory bowel disease. Can you start us off by explaining how mental health is affected by IBD and how IBD is affected by mental health? And what are some of the more common mental health issues seen in patients who have IBD? And what is the magnitude of this problem?
Sure. So I'll get started with just mentioning a bit first about depression and anxiety, which is probably the most familiar to folks listening, and it gets a lot of attention, and for good reason. But actually, we'll start with maybe speaking to the magnitude of the problem with talking about some of the prevalence rates first. We actually know that in patients with IBD, the rates are significantly higher than that in the general population, about 1.5 to 2 times higher. If we break that down, that actually looks like about 1 in 4 patients with IBD struggling with symptoms of depression, and about 1 in 3 patients struggling with symptoms of anxiety. If we isolate even further and only look at patients who are experiencing active disease, that goes up to about 40% of patients are struggling with symptoms of depression and about 60% of patients with anxiety. I think those rates are high, but I think it's even higher when you really think about your clinic day, seeing a dozen or dozens perhaps of patients in one day, and you actually look at your caseload and you think about really how those numbers play out. It's very high.
I've often had people, when we talk about this topic, even say, I know my patients, and I don't think that's happening. So, what do you think about that, and why are we missing it?
Yeah, I think that, well, again, we know that thankfully we're having so much more research on this topic that we know that mental health is just really not getting talked about regularly in these clinic visits. And it's a two-way problem. One is that patients oftentimes are unsure if it's the appropriate setting to let their gastroenterologist or GI provider know. And so they may not bring it up. But we also know that our gastroenterology providers are also sometimes not bringing it up, perhaps because of discomfort with the topic, or perhaps because of very limited and very real time constraints getting in the way of being comfortable delving into that. So yeah, I would absolutely agree. This is something that is getting under recognized even among really fabulous colleagues of ours.
And how does the mental health challenges affect the IBD and vice versa?
Yeah, absolutely. So interestingly, and not the topic of today's discussion, but we do really think that there are indirect and direct mechanisms, right, where the biomedical aspects of the disease itself may be impacting the mental health of our patients, while mental health may be further impacting their disease. The psychosocial burden also goes outside of simply anxiety and depression. I want to also mention the impact of trauma and potentially post traumatic stress in our patients with IBD, body image dissatisfaction, sexual dysfunction, insomnia, disordered eating, to even just name a select few factors that we should be thinking of. But when we collectively think about all of these psychosocial and mental health areas that are impacted, we also know that these are going on to further impact the management of the disease itself, including associations that we've seen with symptom exacerbation, increased risk of flares, hospitalization, surgery, and requiring escalation of therapy. So not only do we need to be thinking about the mental health of our patients as it really is further compounding their physical suffering, but also because it can directly impede the management of the IBD.
I think some people think of this as a chicken and an egg, although often they'll say, well, of course, someone has depression, anxiety, or maybe PTSD because they've been living with a chronic inflammatory condition that can be socially isolating and have other effects on their ability to function. But what you're saying is that there may even be biological connections between these different problems and the inflammation in the gut.
Yeah, absolutely. And I think we're doing some exciting research. Not only we are together and other institutions to really try to get at that, but we have an understanding of these shared genetic and hereditary correlates between psychiatric disease and IBD. And I think at this point, we are going to be further understanding that not only are these mental health conditions, as you said, perhaps more reactionary, but there maybe more biological correlates that could be driving mental health conditions, in particular within active disease, but perhaps even in states of remission.
Some people listening to this may recall the history of IBD, in which the mental health disorder or the presence of anxiety, for example, was thought to lead to the development of IBD. And often patients explain that stress was what they think brought on their inflammatory
Absolutely.
bowel condition. How do you address that when a patient brings that up to you, that they think that this is what caused their IBD, and how should they be trying to address that?
Yeah, I think it's a very delicate conversation, truthfully, one of the more challenging, because I think you do want to respect the patient's experience and truly acknowledge that their experience, that stress likely has played a role, without also making it seem as if the patient caused it because they were too stressed, right? I think that is the sort of inherent balance there. But I also will say that among my patients that really do feel that their experience of stress has contributed to the severity of their disease or associated with flares, they oftentimes actually find it very validating to hear that there is research supporting it. So again, I think at a broad level, I think we have to be just very mindful of how we approach that conversation. But I think, I experience most patients being very receptive and again, finding it really validating to hear that.
Yeah, I agree. And when we bring this up to patients and we try to address it and acknowledge that depression and anxiety are commonly seen in people with IBD for good reasons, and possibly because of biological connections and the way their body is manifesting inflammation, they feel relieved. In some ways, it unburdens them of this feeling that something within them, has a weakness, has led to their condition, which of course we don't believe and we don't endorse. What are some of the red flags people should be looking for in their patients, or if a patient's listening to this at some point, that they should know about themselves?
Yeah, I think, of course, later we'll talk about some of the more direct screening tools that one might use. But I think even beyond that, it's just helpful to sort of understand what depression and anxiety look like. And I talk to lots of, very smart colleagues of mine and definitely patients as well who actually just aren't really aware of what depression or anxiety mean. We talk, these are terms we use in lay conversation, but they aren't actually as well understood as you might think. So just making sure that we are all on the same page. What depression is really talking about in terms of a clinical construct, it's really referring to a persistently depressed or sad mood or a loss of interest in activities. It could be one or the other or both of those things. And then it would be associated with a handful of different symptoms, including difficulty sleeping, changes in appetite or weight gain or weight loss, difficulties with fatigue, and including as well sometimes suicidal thoughts or just thoughts that they'd be better off dead. A major diagnosis that we would use psychiatrically would be major depressive disorder, but sometimes our patients don't meet criteria for that. We might call it a more of an adjustment disorder, depression that might be related to directly to their IBD, for example. But what we might also be looking for is the behaviors in clinic that might point to depressed symptoms. So these might be our patients that are missing their appointments, that aren't reading their EMR messages from you in a timely fashion or at all. They might be having more difficulties with adhering to their treatment regimen, and they might even be displaying anger, irritability, or sadness in their interactions with you or to the rest of the team. When we're thinking about anxiety, we're really talking about an emotional state that's characterized by anxious behaviors, worried thoughts, and physical changes like GI upset or physical tension. More commonly, we might consider that to be generalized anxiety disorder when our patients have anxiety about all kinds of different things. But I also wanted to just acknowledge something that isn't a clinical diagnosis, but more of a construct, GI specific anxiety, which is really anxiety that is more specifically related to GI symptoms or the more IBD related situations. So you might see this among your patients who are very worried about an upcoming surgery or a change in medication or afraid to be away from their bathroom because they're afraid of having an accident. And of course, this could be a very natural reaction to ongoing symptoms, but sometimes it also can become excessive even when symptoms may be improved. So, what does this look like in your patients? Anxiety might look like the patient that is very clearly nervous, jittery, overwhelmed, maybe talking a lot. Maybe they have the elevated blood pressure at the beginning of the visit. They also might be avoiding phone calls or medical appointments because of they're afraid of what they might find out, might be engaging in a lot of online researching, or even more specifically, this might be your patients that have needle phobias or pill swallowing aversions, which can be quite tricky when we're thinking about treatment recommendations.
This is a super helpful list. And I think people listening will be thinking about some patients in their practice where they've just written off them as being irresponsible when in fact it may be driven by an underlying mental health problem, why they're not showing up or answering messages, or conversely, why they're sending lots of messages and looking up every rare side effect of a medication. And so I think people have to intentionally avoid the tendency to find that to be either annoying or to ignore it because it's just one less patient to see, and should be looking for these symptoms and signs that this is somebody who may need our help in other ways.
Absolutely.
So, what are the formal ways that people can try to screen or identify patients with depression and anxiety? And recognizing how busy our practices are and how much we're already asking of the clinicians who see patients with IBD, what do we do? How do we do this?
Yeah. I like to think about this discussion happening in one or two ways. One would be just thinking about the conversation, right? The clinical interview is a great place to start this conversation and to do some of this screening. So, by that, I really mean asking one or two questions. So the first one I always recommend is just simply saying, how are you coping with everything? You're not outright saying, are you depressed? Are you anxious? But coping is a very open ended way to ask people how they're doing. It can really validate that you're concerned about them and build a relationship. And it allows you to also provide some strategies when possible and when indicated. I also would recommend doing this in what we'd call a more permission giving way by normalizing that many people with IBD have some of these struggles. So many people with IBD do struggle with symptoms like depression. Have you noticed any changes like this for you lately? So that's what I would say is kind of the clinical interview style. And then secondly, it would be using self-report measures. Use of questionnaires can be great, right? They're a quick assessment of psychological distress. We have norms that you can use as a very easy reference for how severe their symptoms might be. Two strong recommendations I can make of questionnaires that are validated in IBD include for depression using the PHQ-9, a 9-item screening question, but just be aware it does have a screening question for suicidal ideation. So you do need to kind of be thinking about that and make sure that you have someone present who could review that in real time with the patient. And for anxiety, I highly recommend, and as you know, we use in our clinic the GAD-7, a 7-item screener for anxiety. And so these are great. These are building points. So these should never be given simply on paper on the computer and then not discussed with the patient. They should be reviewed and checked in on, but they can be very helpful in opening up a conversation and determining what support a patient might need.
I know many practices have incorporated the PHQ-2 because it's required now for Medicare, and I'm just wondering whether that's sensitive enough to open the door to this, or does it not get to what we need here?
Yeah, I do think that it's a very good start, but it's really getting at those initial two symptoms of depression that I had mentioned earlier, that depressed or sad mood or loss of interest in activities. I think that that is a very good start, but I also think that we're learning more about how this measure performs in IBD now, but I would say that there are some things that it may be missing in terms of just understanding some of the physical symptoms that could be related to the IBD, could be related to depression or anxiety, or more likely, maybe related to both. So if you have the means to give the PHQ-9, I think that it really takes very little time and it could provide more valuable data.
So I know what all my colleagues are thinking and those who are listening are thinking, which is, well, if you ask, and you've already hinted at it related to suicidal ideation, but if you're asking in general about depression or anxiety or screening using these tools, you also need to know what to do with the results. So give us an overview of practical tips regarding when we should be referring people versus when we should just try to make sure their disease is better controlled and how we go about that because that's a logistical challenge for folks.
Yeah, absolutely. So, when we are thinking about referrals, patients that need further care, recognize that many patients will actually benefit from a referral to a general mental health therapist. And by that, I mean not necessarily someone like myself that's a gastropsychologist. There are many good psychotherapists out there, psychologists or licensed clinical social workers that can provide really excellent support for depression or anxiety. But that being said, it would be very helpful for you as the GI provider or the gastroenterology as a clinic or a department to network with them to make sure that they do have an adequate understanding of the IBD and how that may be related to the patient's presentation. But if possible, whether you have a gastropsychologist that's embedded in your clinic or you are able to access one through private practice, and there are many private practices that exist throughout the United States now, these are really wonderful resources for our patients with IBD where they can get more specific care related to their mental health and these other types of psychological and social distress that is going to be more personalized to their IBD, working with providers that have a better understanding of that.
So before our group at the University of Chicago was blessed literally to have you leading a group and now your partner here, we had developed a list of providers in the area who had some interest or knowledge and even reached out to them. But what other patient resources are available for our colleagues if they want to develop that list for their patients and start thinking about this more intentionally?
Yeah, absolutely. So I would probably start with thinking about referral directories that can be looked up online. And I'll say the websites here. So for folks that might be interested in looking into gastropsychologists or other GI specific mental health providers, I would recommend looking at the romegipsych.org directory, which is a directory of mental health providers that have experience in psychogastroenterology, and you can search by state, though many psychologists are able to practice over state lines, though there's a lot of caveats to that.
Does Rome refer to the functional bowel criteria, that Rome?
It absolutely does, yes. And so our professional organization is subsumed under the Rome Foundation, but it's really, we are working across the span of all GI diseases. So it includes folks who would be specializing in IBD as well. Beyond that, I would actually be able to recommend an excellent book written by a gastropsychologist, a colleague of mine, Melissa Hunt, and it is titled Coping with Crohn's and Colitis, a patient and clinician's guide to CBT for IBD. This was just published within the last year or two. It's an excellent book, really would be something totally appropriate for not only our providers to read, but also for patients to read and to really get some nice evidence based strategies for coping with more IBD related distress, including depression and anxiety. And then, of course, can't forget to mention our Crohn's and Colitis Foundation's webpage. They have a whole page on mental and emotional well being, which is very easy to find by just doing some basic web searching. And it has a really nice list of resources on there, a really nice list of articles that patients can read, just being able to be better informed about that connection between their mental health and their IBD.
Well, this has been an amazing conversation, Elise. I really want to thank you for being with us, and I hope that our colleagues will be taking this back to the clinic and helping those patients who are in need.
Thank you.